So that's what I kind of like about the ER. You really just never know what you're going to get. You never know how the labs are going to be. Nothing is ever completely textbook, and you're always going to be learning. Hi, everyone. Hello. Hi, guys. Hi, guys. Yes. Hello, everybody. Somebody already said, is there an actual shadowing tonight? Yeah, there's always a shadowing. It's just that I'm the host and the guest. We don't have an actual guest for tonight, so I'm going to do an emergency medicine session. Hope everybody's doing well. Remember I said that usually I do like a Q&A. If you guys still want me to do a Q&A, I can answer a few questions, but I haven't actually done an emergency medicine session in a long time. Like since I started this, that was the very first session that I did. So I'll do a case study today, and it will be an interesting case study as usual, and a good one. So are you guys excited and ready? Okay, let's hop right in. I guess we can start with a Q&A if you guys have any questions. I'm going to try to keep the Q&A really short, like 20 minutes. And yes, we can hop right into it. Okay. Yeah. And as usual, you will get credit for this as long as you take the quiz. So yeah. So for emergency medicine, I work in emergency medicine. That's why I don't mind doing the sessions. I can also have another guest come on that's in the ER, so you can get a different perspective. But yeah, I love the ER. I also do have some urgent care experience. I do urgent care back in Atlanta, but right now I'm doing ER in New York, as you all know. And I also did ER in Atlanta. That's where, like, since I've been a PA, that's basically what I've been doing. I've been doing ER for over 3 years. All right. How many on-call days do you have a month? 0. We are never on call, thankfully. Emergency medicine is kind of like your typical job. You punch in, punch out, leave, go. That's it. You're never on call. I don't really know of any ER job where you're on call unless you work per diem. But not on call. The quiz is never up until the end of the session or a few hours of the next day. What's your day like before and during the pandemic? Okay, so before the pandemic, this is from my experience in Atlanta. Before the pandemic, I work in a very, very, very busy ER. It's the second busiest. Oftentimes, we're kind of like on a seesaw with Grady Hospital. If you guys don't know what Grady Hospital is, it's like the #1 trauma center in Atlanta, and I think the #1 trauma center in the South, period, but don't quote me on that. But I work in Metro Atlanta. I work in the second busiest hospital after Grady, but oftentimes it's probably slightly more busier than Grady, but Grady is a trauma center. My hospital is not. It's a Piedmont affiliated hospital, and it was very, very, very busy and hectic. And it's a county hospital. It's like the only hospital within 3 counties, so we had a lot of patients coming in. So that's all I could really say about it. It was busy and chaos. When COVID started, it was still busy, like that March time, and that was like the time that like I was working like 6 days in a row. I remember I worked like 6 days in a row, and I had like 1 day off, and I had to come back on. And then like things just changed from my 1 day off. Like everything went from like, okay, everything's normal, to like, boom, like everybody's asking about COVID. Everybody's worried about COVID. Everybody thinks they're sick. It's just like, what are we doing? And then we didn't even know what to do in the ER because like the world didn't even know what was going on. So we didn't really know what to even tell patients, really. And so we were just kind of telling them, you're not really sick enough to be admitted. We're not testing. We're just kind of going off what the reports, like what they were saying on the news. And then that's when we shut down, I actually stopped working in the ER full time. That was planned. So it wasn't like, oh, I just decided to do it because of COVID, but I was still working in the ER and urgent care. And then it became like a ghost town. I just wasn't working as many hours, but it was still like a ghost town, like, because we were on lockdowns and people were afraid to go to the ER. So and they stopped surgeries. The hospital wasn't as busy in terms of like regular stuff, but that worried me because it's like people weren't coming in for like the typical stuff. So it's like what y'all doing? So it's like, were y'all going to the ER just because like y'all weren't really sick, or are you guys really sick and avoiding the ER, which is bad because I don't want you to be at home dying or avoiding a serious illness in fear of COVID. And that's what I've come to kind of see. Of course, COVID is going to kill you, but you don't want something else to kill you. And so I tell my patients that, especially if they call me, because I also do urgent care, and we adopted virtual visits. So patients would come in with these complaints of chest pain. I'm like, you need to go to the ER, but then they're scared. And I'm like, no, a heart attack or something more serious could kill you. I mean, it could be COVID, it could not be COVID, but we still have to think about other diseases. And I think that's what the world kind of forgot, that there's other things that can still kill you. So that's what the change has been. Like, patients kind of became so worried about COVID that they forgot other stuff. And then it started to pick back up. And I don't know how New York and hot spots were like. Thankfully, Atlanta was never like a crazy, major, crazy, busy, people falling left and right. But yeah, in New York right now, it's fine. I heard yesterday that 75% of admissions have been COVID, and I have had quite a few COVID patients. So it's just like, when is this gonna end? Like, it's trying. I mean, especially as a provider, wanting this to just be over for patients, and of course, just for your sanity, for the world. So I hope I answered that question well. I told you I'm not on call. How do you make your application stand out if you have a low GPA? If you have a low GPA, just shine in other areas. I'm sure like your other parts about you are not bad, such as your volunteer, shadowing, especially healthcare hours. If you have a low GPA, really, 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 really work on building your healthcare hours, okay? Try to have way more than 2,000. Shine in other areas. Show that you are multifaceted, that you have all this volunteer experience, that you're well-traveled, that you do other things, that, you have hobbies, that, that's something you did or something's made up for that low GPA. So that's what I'll say. I don't think any GPA is too low to say, oh, you can't get into PA school. I think, that everybody's capable of getting into PA school. But that's just me being optimistic. Do you have to go through residency? You do not, but there are ER residency programs. I work in Brooklyn, New York. What is your schedule like being an emergency medicine PA? Okay, so if you work in the ER, thankfully, you'll only work like anywhere from like 12 to 14 shifts a month. You can always pick up more shifts, but because you work longer hours, you're going to work less days in the month. So when I was working in Atlanta, I was only working 14 days out of the month. It was amazing. So, but it was 10-hour shifts. So I was like get 140 hours a month. So for a lot of companies or agencies, whether you work for the hospital or an agency, I've worked for agencies my entire ER career. I've never worked for the hospital before. Right now I work for an agency, and you guys will learn all about this once you become PAs. Or I can probably do a session on it or discuss it more during another Q&A. But I work for an agency. The agency pays me. The agency tells me my hours, and I go to the hospital. So it's 10-hour shifts in Atlanta, the agency I was working with before, 140 hours a month. But to be considered full-time, you just need 100 hours, which is like nothing. But right now in Atlanta, in New York, now that I'm working for in New York for this COVID, I make up my own schedule, and I decide to work. Well, they want you to work at least 4 days a week, so I decide to work 6 days a week. So, yeah, and it's 12-hour shifts. So I work like over 200 hours a month, sometimes close to like 300 or 300. How stressful is it working in the ER? It's very stressful. Why did you choose ER? Because you will always, always be learning. It's never boring. One day you'll see this, or one day you'll see all these things. The next day you'll see a whole set of new things. You'll see anywhere. You'll see everything in the ER. That's why I love it. I like, as you can tell, my personality, I'm very bubbly. I like excitement. I'm a thrill seeker. I love to do I like the adrenaline rush. I like to feel like pumped up, and I get that from being in the ER. Like I said, you'll never see the same thing. You'll see patients with chest pain, abdominal pains, headaches, every system, everything you can think of, you'll see it in the ER. One day you'll probably get a bunch of lacerations, a bunch of chest pains. I don't know. You'll just see everything. That's what I love about the ER. That's why I decided to do ER. I can't do any other specialty. I can't see myself doing any other specialty because I don't want to come to work and see all the same patients, all the same conditions. And yes, I mean, in the ER, you'll end up seeing a lot of the same things, like your typical chest pain, your typical abdominal pain, your typical kidney stone, headaches, and you'll learn how to treat them just like systematically. But it's just that out of the blue you get something else. But even if you get that your typical chest pains, you'll see a lab that just kind of throws you off, or you'll see something that kind of throws you off and changes your treatment plan. So that's what I kind of like about the ER. You really just never know what you're going to get. You never know how the labs are going to be. Nothing is ever completely textbook, and you're always going to be learning. Yeah, your schedule is really going to depend on your specialty, and a lot of times you can make your own schedule. So it depends on your specialty, but at the same time, you can kind of make your schedule, like depending on where you work or how lenient your team is, that company culture. So like you can say, oh, these are the days that I'm available. Or if you work at a regular, clinic, oftentimes it's just going to be Monday to Friday, holidays off and whatnot. And of course, if for the most part, the only time you're really going to be on call is if it's like a surgery. If you work any specialty that has a surgery component, like OBGYN, you'll be on call for that, or a hospital component where you're expected to be in the hospital. OBGYN maybe. I know other specialties can be on call if their providers work in the hospital, like nephrology, GI, and all that. But yeah. It's really if you're also hospital based, and if you have to go into surgery at any point. So, okay, let's see. Yes, the ER is very stressful. I don't know how to answer how stressful is the ER. It's very stressful. Do you think? Yeah, I think the PA career that can definitely grow. As PAs gain more autonomy and the laws change. The quiz is used for you to get points. I'm going to let anything related to the quiz, I'm going to let students that have been here longer and more familiar with the answer to the questions. I'm going to really just be answering ER related questions. Emergency medicine versus urgent care. Okay, you'll see a lot of urgent care in the ER. Urgent care is for less emergent cases. So a lot of the urgent cares will be cough and colds, people that are stable, people that are always going to go home. But in urgent care, you'll see a lot of emergency medicine, which means people that need to go be evaluated in the ER for an emergent thing. When you think of emergency medicine, it's not always going to be the case, but think of life and death. Think of if this person doesn't seek care, they could potentially die. Or this person needs to go to the hospital to prevent a potential death, and potential death as in like, oh, it needs to be handled within the next 2-3 days. Okay, if they don't get this, they may die. So that's what you think of. Urgent care is, like I said, less emergent. It's like, okay, you're sick, you're really not doing well, but you'll make it, you'll be okay. So you can think of like cough, colds, some abdominal pains, viral type of stuff, like viral gastroenteritis, UTIs. You'll see all that in the urgent care. Fractures, lacerations. You'll see a lot of lacerations, a lot of procedures in urgent care. The only time with procedures like lacerations, abscesses that they'll go to the ER is if you're worried about nerve damage, is if it's a really bad laceration, if it affects the hand and it's really bad. With the hand and lacerations, if it's really bad, you always want to refer a person to a hand specialist or if it's bad enough to where, you really think that they need to see a hand specialist right away, try to get them there. It's somebody's hand. That's a lot of liability because you need your hand, especially if they work with their hands. Don't ever forget that. So always refer them to a hand specialist after. And I'll say give little advice here and there. I know you guys probably won't always remember it, but okay. So that's the biggest difference between emergency medicine and urgent care is the level of acuity. Urgent care is less acuity. So think of urgent care as like a fast track type of thing, or in the emergency medicine. Emergency medicine, you'll have a fast track area, which is patients that can be in and out, patients that you can see within like an hour and a half, 2 hours, and they can leave, and they don't need much tests, many exams. They probably need one exam as far as like one lab test, and whether it's like a urine, a chest X-ray, or an X-ray of a joint or whatever. What is your level of autonomy as a PA in the ER? That varies. That's what I can say. It varies based on where you work in the company culture or that hospital culture. For the most part, you are pretty autonomous, but I've heard some horror stories of some hospitals or some practices or groups where doctors like kind of didn't really respect PAs and kind of really treated PAs like assistants. I've had that experience. I'm not your assistant, okay? I'm nobody's assistant, okay? Maybe that's where the issue comes with the name. They are trying to change the name of physician assistant. It's not physician's assistant with an S. It's physician assistant. Like, I'm your right hand. We work together. I'm not going to take orders from you. I'm going to consult with you. You understand what I'm saying? Like, we collaborate. Not, oh, you do this, you do this, you do this, you do this. No. So I do my thing. If I need your assistance, I'm going to tell you. Or if I need your help, if I need whatever, I'm going to tell you. And then I'm going to also, like, let you know about what's going on, update you. But in some practices, like where I work in Atlanta, we don't have to run patients by the doctor. We do our thing. We do whatever we got to do. The doctors are on one side. We are on another side. And we do what we got to do. If we need to, yes, the physicians are there. How can you get involved in research as a PA? Maybe by working in a school, maybe by going to school, working in a school. I'm not really sure how to get involved in research, or working in a school, working for the CDC. I'm not sure as far as like how to get in there. Working for the CDC, school, public health. A lot of PA programs also have a public health component where you get your master's. Okay, does a medical scribe do your charting of a lot of patients? I've never had a scribe. I've worked in places where I could have got a scribe, but a lot of times they give doctors the scribes, and the PAs, you have the option, I've heard, but that comes out of your paycheck. But we really, I like doing things on my own, but the doctors really have the scribes. That's what I've seen. What type of volunteering did you do before PA school? Volunteering that I do. Let's see if I can remember. Oh, well, duh. I've always loved mentorship. So the volunteering work that I did before PA school before and after PA school was Big Brothers Big Sisters of America. I was a big sister. I've been a big sister since high school. So I went on to do that in college. Well, college, I wasn't really a big sister, but I interned for them. And then after college, that period, that my 1 year gap, I also did more Big Brothers Big Sisters. It just naturally comes to me. I just absolutely love helping, giving people advice, giving people the right advice, I hope. But mentorship, helping our youths, really working to change the people's lives, and especially people that aren't as fortunate, that aren't as privileged as myself. Really giving back in that way. So it just kind of comes naturally to me, and that's why I love virtual shadowing and helping out with you guys. Do you do rounding? This hospital, we do rounding. This hospital that I'm at right now, surprisingly, we do round. And we round on patients in the morning. Round as far as ER patients, not hospital patients. So rounding is when you go around and the providers discuss the patients. You actually see the patient that you're talking about. and you run through their, why they came to the hospital, run through the case, why they came to the hospital, any updates on them, what you plan to do for them. What was your first day in the ER room like? Dang, I'm trying to remember what my first day was like. I honestly, oh, okay, so this is a very, I'll share this with you guys. This is, I don't know why it took me a while to remember this, but this is the last thing I'll hopefully talk about before we start the case study. My first day in the ER was very memorable because it was also a very sad day for me because, it was my very first day in the ER, and it was Valentine's Day. It was Valentine's Day 2018, 2/14/2018. I was very excited to start the ER. I was working with a PA. She was really amazing. She was really good. She trained me so well. Not just her, but the other PAs that I trained with. And the doctors were great. I think I really had a good start in foundation. It's really who trains you in the ER, and she's really good. But I was working fast track, and it was like fast track / screening patients. Screening patients is when you see every single patient that walks through the ER, or the majority of them that walks through the ER, and you make sure that they're you start ordering labs on them, make sure that they're stable enough to kind of wait in the waiting room or get a room right away. And it's kind of starting things off. You start off by ordering labs on them or imaging and simple medications that they may need. So we were screening patients and doing fast track. And so it was really, really busy. And so I was doing that, and it was a lot to learn. And I wasn't on my phone at all the whole day. And the only reason I remember my first day is because of that happened. I wasn't on my phone at all the first day. So I was just like trying to catch everything in, wondering if I'm even good enough to be working here. Because I'm like, dang, this is a lot to learn. Even though I learned a lot of it in school, most of what you really are going to learn and get comfortable with is going to be, from actually doing and learning in the field. So I was stressed with that, but I haven't been on my phone the whole day. First of all, I was scared to be on my phone because I don't know how, that workplace is. Like I said, a lot of it is going to be company culture, getting used to that environment as well. So I get on my phone and I see all y'all, nobody be texting me. So I had over 20 text messages asking me, are you okay? Are you okay? Is your brother okay? Blah, blah, blah. And I'm like, what are you talking about? And then I go on break and I see the news. I'm from Florida. I'm from an area in Florida, South Florida, near Cold Springs, but it's called Parkland, Florida. And I go I go to the break room and I see shooting in Parkland. And I'm like, what? And I'm confused because I'm like, okay. And then it says Stoneman Douglas. And I'm like, okay. And I'm over here at work, my very first day of work. And my little brother went to that school at the time. And that was the same day that I started in the ER was the same day of the mass shooting in my hometown. And I was devastated because I'm here working, and imagine me working in the emergency room, and then over at home, my family is distraught, going crazy because of this mass murder, and then in the emergency room in my hometown is crazy. So that's why I remember it, because I'm from Parkland, so the Parkland shooting, unfortunately, that occurred that same day that I started working in the emergency room. So yes, it was a really, really sad day. I'm so glad that shout out to Stoneman Douglas. I went there my very first year for high school, then switched to magnet school, but my brothers went there. My brothers went there all 4 years. My youngest brother was actually there at the time of the shooting, unfortunately. I mean, thank goodness he survived, but yeah. So, and speaking of ER, thankfully I've never had to witness a mass murder, mass deaths in the ER, what's it called? natural disasters where, you know, there's a ton of people in the emergency room. Even with COVID, I wasn't, you know, like I said, Atlanta wasn't hit that bad early on. It wasn't like New York. I heard New York was like terrible. I mean, we all know New York was terrible, but like from PAs and providers that were actually there, it was like horror. Okay, so I'm getting back on the computer right now. Yes, mass casualty event. Yes, I had prior experience that led me to pursue PA school. I was an LPN. I didn't really introduce myself or talk about my journey because I feel like I kind of do that all the time. But really quick, I was an LPN before PA school. I went to magnet school. Like I said, I went to Stoneman Douglas my very first year, 9th grade in high school. And then the remaining 3 years was Blanche Ely High School. That was a magnet program. My parents made me go there because they wanted me to be a doctor and get all that experience because it was a healthcare magnet program. So I was going to be in the nursing program there. It was like the best thing I've ever done my entire life because it opened doors. It opened the door for me to go to work in college, make really good money in college as like a 19, 20-year-old, then get that experience for PA school, then become a PA and just all of that. I'm so happy that I did that. I was in the nursing program, LPN program, completely free. And I, you know, did clinicals. My last year in high school, I was doing clinicals. I graduated. I technically graduated high school or finished on my prereqs for high school my junior year. So my senior year was all LPN stuff. So I was able to work in college. I was making like $18 an hour, which is amazing for an 18, 19-year-old. And that's how I got experience. And that's how I was introduced to the PA career because PAs rounded at the nursing home that I worked at. And then I ended up searching the PA career. And yeah, and I had all these hours from work. So that's why it worked out. Can you intubate and do all that in the ED? Yes, you can. Do PAs do that? Not always, not typically. I feel like PAs, I mean, you can, but doctors usually kind of just take over during codes and level 1, level 2 cases where patients need to be intubated or put on a vent and all that. Can PAs do it? Yeah, but oftentimes I see PAs do all that in critical care, which is ICU. Okay, so let me get started with the case study, guys. All right, here we go. Yes, got it. All right, I love discussing emergency medicine. Yes, I think Scribe is the best. Okay, so this is especially great for anybody that wants to get into emergency medicine. So if you guys have any questions, and I want you guys to be super interactive. So if you see questions that I ask, please answer them. It's really fun, and it makes me happy. Okay, let's get into it. Okay, for emergency medicine, these are some pearls that I want you to remember, okay? Always, always, always think about what can kill your patient. Even if they come in with the simplest complaint, make sure you always rule that out. Ask the questions that are going to rule those things out to where you feel comfortable enough to discharge the patient, okay? I'm sorry about that. To where they are comfortable enough to discharge, where you are comfortable enough to discharge or admit the patient, okay? Always constantly be thinking about, are they sick? Are they sick enough to be admitted, or can they go home? Be considering your differential diagnosis. Differential diagnosis basically means different things that you think is going on with the patient. Possible diagnosis that you have in mind. Usually it's 3, or you narrow it down to the top 3 things that you can think of. And then consult. Oh, never feel like oh, you know, like, or feel uncomfortable to where you feel like, oh, you can't consult the doctor or a specialist or anybody like that, because that's what they're there for. So always think worst first. If you don't learn anything, it's that. I'm sorry, I'm in New York. It's loud all the time. It's driving me insane. Okay. So in emergency medicine, like I said, it's always going to be how sick is the patient, stable versus unstable, from when they walk into the ER to when you can determine that disposition of them discharging or being admitted, okay? From start to finish. So they get triaged by the nurse. thinking sick or not sick. That's how they base them on ESI level. That's their level of acuity from level 1 through 5. 1 is basically dead. Level 1 never walks into the ER. They will usually EMS. Level 1 and 2s are usually EMS. The one time I've seen a level 1 or level 2 get to the ER was when my brother, quick story, my brother had a really, really, really severe allergic reaction, like angioedema, like just, it happened so quick. I was home with him. He has allergies. And I went from seeing him just kind of have hives. It happened really quick. From seeing him just have hives to like within like 5 minutes, his face blew up. I'm like, dang. Like, I think we called 911, but I'm like, dang, I'm not going to wait. I'm going to rush you to the ER. By the time we get to the ER, my brother's face was huge. Like, he could barely breathe. Like, I was terrified. I'm like driving like crazy trying to get him to the ER. They immediately brought him in, gave him epi, gave him steroids, gave him all this. He had to stay in the ICU. So that's the only time you'll probably see a level 2 crazy people like me. I didn't want to wait for EMS. You know, they were taking way too long. But now he has an EpiPen, but my brother had a very, very severe allergic reaction. His tongue was huge. Like, he could not breathe at all. So my brother would have been considered a level 2. But I'm crazy, y'all. Don't do that. So, yeah, that's a quick story. Okay, back to what I was saying. ESI level 1 through 5. 1 is usually cardiac arrest. 5 is like basic. They don't really need any resources. They'll be in and out. That's like suture removal. Maybe they're coming for like a pregnancy test or something. We don't deny any patients. There's EMTALA, which is a law that basically says you can't turn anybody away, whether they have insurance, whether they don't, whether they're coming in for the stupidest things. We screen them, make sure they're stable, have them in the waiting room, assign them an ESI level, and see every single patient that walks through the ER. Okay. And then from there, they get a bed assignment. So they'll either go to a lesser acuity level of the hospital, like a fast track, or like a fast track of the area where the doctor's in, or, you know, they'll be good enough to see the PA. Or, like I said, depends on where you work. The PAs and doctors may work together, and PAs can see any and everything. Typically, PAs see levels 3 to 5, doctors see levels 1 and 2, and then 3 to 5 and whatever. But PAs rarely ever see levels 1 or never see level 1 on their own. Like I said, level 1 is like cardiac arrest. Level 2 is close to death, but level 2 is going to always be admitted. Level 3 is kind of the gray area where they're stable, but they may go home, they may not. 4s and 5s always typically go home, or typically. Sometimes they miss triage and they'll put a level 4, a patient as a level 4, but they're really a level 3. I've had that before. I've had to admit level 4s in the past where I've worked in fast track and the patient really is not a level 4. So always do your due diligence. Don't ever like look at what somebody else writes and think, okay, there's nothing wrong with them. If a triage nurse thinks the patient's level 4, always, you know, ask them the right questions to make sure they are truly a level 4, truly that sick or truly not that sick. And just do your job, do what you have to do. And even if the patient was asked the same question a million times, the patients will get annoyed. Still ask them the same questions because you're the provider. It's going to come back on you. So yes. Internal bleeding. Internal bleeding is not always going to be level 1 or 2. It depends if the patient's stable or unstable. Always go back to that, stable versus unstable. And you'll know that based on their presentation, based on their vitals, based on where they are in the ER. So if the patient, you don't know if a patient's internally bleeding when they come in, unless they tell you, and oftentimes they're not going to say, oh, I'm internally bleeding, unless they know that they have an ulcer or something. So you'll see their vitals. Are they hypotensive? Are they tachycardic? Do they look very pale? So that can give you an idea of whether they're internally bleeding. But if a patient comes in with saying that they have blood in their stool, they'll likely be a level 3 unless they're unstable. They're never usually a level 2 or 1 for internal bleeding unless, you know, it's a known diagnosis and they're like super hypotensive and on the verge of like a cardiac arrest. I hope I'm not talking too fast. And I hope you guys don't mind if we go a little bit over, but this is really going to be a fun case study. Okay, last, as far as who's going to evaluate or pick up that patient, every ER is different. For the most part, level ones, all level ones, the doctor will see. Level two, some PAs will see, PAs or nurse practitioners will see. Nurse practitioners do also work in the ER. We basically all do the same thing as nurse practitioners. And it also, like, some ERs are built differently. They'll have the PAs on one side, doctors on another side, PAs and NPs on one side, doctors on another side. Sometimes they all work together in one area. So it just depends on where you work. I'm not really answering any more questions anymore. So if just general, unless it's related to the case study. If you have questions, just email or DM me. Okay, so as I said, always be thinking stable or unstable, sick or not. From the minute you get that patient, you're going to look at that patient, have an idea. It's not always going to be the case. You may look at them and say, oh, they look really sick, and they bounce back really quick throughout the course in the ER, and they may be fine to go home. Or they may look perfectly fine and they need to be admitted. But for the most part, you're going to have an idea of whether this patient is actually sick or not, or stable versus unstable. Okay. Okay, I'm sorry, I was trying to read a comment, but I'll answer that later. Okay, so this is the case study. A 66-year-old female presents to the ED complaining of cough and shortness of breath. These are her vitals. She's coughing. Help me, I can't get up. Sorry. Okay, her vitals are 101 temp. Her heart rate's 82, blood pressure is 165/94, respiratory rate is 26, oxygen saturation is 92%. And what's going to already be in your differential? What are you thinking? What are you going to be asking this patient? Okay, sorry, that lady just looks like, help me, I can't get up. Okay, so what's going to be in your differential? What are you going to already be thinking when you see this patient? Okay, and let me tell you guys really quick, in the ER, that blood pressure is it's high, but it's fine for the ER. Usually we don't treat blood pressure unless it gets like in the 180s, 190s, over 100s, and the patient has signs of end organ damage, which is going to be by their blood work or by their physical. But 165/94, especially if they have high blood pressure, we just kind of monitor. We don't necessarily treat with medications. If it goes like higher than that, then sure, but in the ER, that's not, too alarming. Okay, so what's really standing out with this patient? Okay, what's really standing out is somebody said pneumonia, which is good, but what's really standing out is her oxygen saturation and her respiratory rate. She's obviously in distress. And being that she's 66 years old, you're already probably thinking, okay, this patient's 66, her vitals are weird, she's probably going to stay in the hospital. So what are you thinking that she could have? Somebody already said pneumonia. Somebody said COVID. Hypoxic, she needs oxygen, she's hypoxic. You guys are so smart. She's coming in with shortness of breath, and she clearly is short of breath. So all of this is the chief complaint, of course, is subjective, but a lot of, your assessment's subjective along with objective. Okay, you guys are amazing. Awesome. Yes, what's her past medical history? Let's go on to that. I don't know what her past medical history is. Y'all gonna have to tell me. Okay, so the next thing you're gonna do, you look at the patient, she's coughing. Okay, so she's coughing, she's in respiratory distress. So you're already thinking, okay, this patient is sick, this patient's kind of unstable, this patient may decompensate, so I got to act quickly, I got to figure out what's going on with her, I got to, start some intervention. But first, so you're already kind of thinking all these things when you look at the patient. So the next thing is, of course, going to be to get a history. And all of our histories in the ER, you're not going to spend more than, sometimes I'd be in the room for 15 minutes, the patient but usually if you're in the room for 15 minutes, the patient's pretty much stable. You're probably going to be in the room for anywhere from 5 to 10 minutes between getting a history and physical. So you're going to get your history. Everything is focused, which means you're going to focus in on that one thing going on, okay? But you want to ask all the right questions. So if she's complaining of cough and shortness of breath, what is everything related to cough and shortness of breath? What are all the systems related to cough and shortness of breath? So what can be causing that? Your lungs, so you ask all the lung questions. Your heart, so you ask heart questions. Are they having any chest pain? Do they have any heart conditions? What's their past medical history or any cardiac history, any lung problems, COPD, bronchitis, asthma? So that's what your history is all going to focus on. Of course, you're going to do your OPPQRSTA. Some of them will not be related to that complaint, like what's going to make it better or worse. I mean, you can ask what makes the cough better or worse, but that's really for pain. So you're going to want to know the onset, quality, radiation. That's going to be for pain. Onset, timing, any associated symptoms, really with cough and shortness of breath. If they have any chest pain with this, if they're clearly she has a fever, she might not have known that she had a fever. She could have said she had a subjective fever. Subjective fever basically means that the patient's telling you they have a fever, but they actually didn't quantify with objective measurements, such as getting their temperature. And then the past medical history. Like I said, I didn't create a past medical history. You guys don't have to tell me if you want her to have a past medical history. She's 66, so maybe she has things going on, such as maybe, okay, let's say she has COPD. She has COPD. She's a past smoker. Social smoking, alcohol use, that's all going to go under social history. Family history. Does she, if she's complaining of chest pain, does she have any family history of heart attacks? So past surgical history. A lot of times these 4 things, past medical history, past surgical history, family history, and social history, all of that is oftentimes going to already be in the chart. The nurse may already ask them that, or they may fill that out when they do their paperwork. So you may not need to ask them that. You'll probably already see it when you go over the patient's chart. So what I like to do before I see patients is open their chart, of course, check their vitals, but kind of do a little run through, see if they've been to the ER in the past, see if they're kind of a frequent flyer, give me an idea of the type of person I'm going to, be talking to, see if they have, any past medical problems. So that also, like I said, gives me an idea if this patient's going to be admitted or stay. Yeah, you guys are asking some great questions. And then you ask all these questions. And wait, does anybody want to come on with me? If you want to come on with me, just let me know. If you want to come on the session with me, I forgot to ask you guys that. I'm sorry. If you want to jump on the live and answer questions, you can. You guys are asking some great questions. Does she have a history of cancer? You would want to know that. Any respiratory issues? You'd want to know that. Travel, recent travel, yes, it's very important. Allergies, yes. If she's wheezing. Okay, next for the physical. So for the physical, like I said, focus. You want a focused exam. So you're going to listen to the heart and lungs. Always listen to heart and lungs, whether they come in complaining of a headache or of abdominal pain. Listen to heart and lungs. And is head, eyes, ears, nose, and throat. Look at their pharynx, their posterior pharynx. Listen to the heart and lungs. That's really what you're gonna do for this person. If you're listening to the lungs, is she wheezing? Does she have bronchitis? Does anything sound weird? Does she have any heart murmurs? Is her rhythm normal? Is she an AFib possibly? Is she a smoker? Yes. So that's the physical. Say you listen to her lungs and she has decreased lung sounds and she's wheezing throughout. She has expiratory wheezing. Expiratory is when she exhales. She has wheezing. So she's wheezing, she's short of breath. All right, medicate and labs. What meds do you want to give and avoid for this specific patient? Can fluid buildup in the lungs lead to this? Yes, fluid buildup in the lungs can lead to cough and shortness of breath. So some labs that you want to order. Can you guys answer some meds that you want to give and avoid in this patient? Some labs that you want to order, CBC, CMP, you're always going to, those are basic labs that you're always going to order. EKG and troponin. This is a 66-year-old female. Even if she says she's not having chest pain, she's having shortness of breath, she has just her age alone is a risk factor for cardiac conditions. So you want to make sure there's no underlying like ACS going on. Troponin is a cardiac marker, or just to make sure it's not a potential heart attack or stress to the heart. Get an EKG. For the most part, she'll likely have had an EKG done at triage. EKG done within 5 minutes of presentation. Depending on the complaint, all chest pains, of course, get an EKG. All shortness of breath, get an EKG. Sometimes if they're older and complaining of abdominal pain, they'll get an EKG, especially upper abdominal pain. Lactic acid and blood cultures. We would do that in this patient. Why would we do lactic acid and blood cultures? You don't have to know this. You absolutely do not have to know this. But this is important to know. If somebody can answer that. And what specifically for this patient do you want to order? EKG is electrocardiogram. Measures electrical activity of the heart. You wouldn't necessarily be thinking of alcohol use because she's complaining of cough and shortness of breath. Maybe if she's complaining of abdominal pain, but okay, she may be able to get a breathing treatment. Lung function test, you don't do lung function tests in the ER. CBC is complete blood count. It gives you your white count, your hemoglobin, hematocrit, lymphocytes. CTA chest, not go to that. Not lung function test. Come on, guys, this is really easy. What do you want to order on a patient with cough and shortness of breath? An X-ray, yes. Cough and shortness of breath. Cough and shortness of breath. Cough and shortness of breath. I think it's just, you guys are so used to this that it's like you're missing it. Yes, Anika, COVID test. Yes. COVID test. Okay. So, what is the most important imaging test? You guys already said it. Chest x-ray. So a lot of times your chest x-ray may be done and come back before your labs. Labs can take anywhere from an hour, hour and a half to come back. Okay? So your chest x-ray is done and comes back. The radiologist reads it right away and it shows this. So it's very icky. Chest x-ray, it's supposed to, like, the lungs are supposed to be black because that's air. Whenever it's white, you know, kind of think of something going on. It's like, you see like these opacities, that's what they call them. So this patient has ground glass opacities. When COVID first came out, everything started back in March. A lot of what we were seeing, because we weren't doing COVID testing in the ER, I don't think we started doing, we were doing COVID testing, but we weren't doing them in the ER unless they got admitted. So we would do chest x-rays and then maybe do a CT, and it would be showing like ground glass opacities. And that's what we came to find out with COVID. It's a lot of their chest x-rays were showing ground glass opacities. So before the lab would even confirm COVID, we would have an idea that it's COVID because of this. Ground glass opacities is the name given because it's basically the air spaces are filled with something other than air. So it could be fluid, it could be fibrosis. In the case of COVID, it's likely like fluid or just damage to the alveoli, which causes your lungs to look like this. So, and I think that's going to be on a lot of exams coming in the future. So definitely when you guys start PA school and do your pulmonary section and then even take your PANCE, I think they're going to associate ground glass opacities with COVID. It doesn't mean that it is COVID. It's like saying if a patient has right lower quadrant pain, that is appendicitis. It doesn't mean that it is appendicitis, but you associate it with that. So I think with future exams, that's what they're going to do. They're going to associate ground glass opacities with COVID, because that's what we see all the time. I saw it like last month when I had a patient. I had like a 20-something-year-old male, and he came in complaining of cough, shortness of breath. He passed out. He was coughing up blood. Did a COVID test, and all of that was pending. Did a chest x-ray. He had bilateral pneumonia with ground glass opacity. His lungs basically look like this. But yeah, you'll have like it'll show like a pneumonia pattern with the ground glass opacities. Okay. All right. So this is what happens when I guess I'll get into the pathophysiology a little bit later. So your lab work comes back, and nobody answered the lactic acid and blood cultures question. Lactic acid in blood cultures is done to make sure the patient is not septic. Which is like a severe infection. A lot of times due to bacteria, but anything can cause sepsis. Sepsis is basically your body not basically responding well to infection. Something bad can happen to where your body can shut down. You have multi-system organ failure. So we work to recognize sepsis, but mainly treat sepsis. So that's why we do that. If the patient comes in with fever, abnormal vitals, we're in potential infection, we're automatically thinking of sepsis. You'll learn more about it in school. I'm not gonna get too much into it. So these are her labs. She has a normal white count, decreased lymphocytes. You'll see that with the diagnosis. Lymphocytes, think of your immune system. Lactic acid is 2.5. So you're thinking potential sepsis. Blood cultures are pending. Blood cultures take some time to come back. And guess what? She's COVID positive. All right. Yeah, it's COVID. Okay, so why is COVID so bad? I wanted to discuss this because I feel like you guys are going to see it, of course, and learn about in PA school, but it's such an issue now, especially in the ER. So COVID is bad because of what happens. The virus enters the cell and attaches to an enzyme called ACE. ACE is angiotensin converting enzyme. You'll learn all about angiotensin converting enzymes because it affects blood pressure. It can affect the kidneys. It's it's a lot of different areas in the body, but mainly in the lungs. There's like angiotensin converting enzyme 1 and 2. 1 is in the heart, I believe 2 is in the lungs. So that's the reason that the lungs are mainly affected, because of where that enzyme is predominantly found, which is the lungs, as I said, but it can be found in other areas of the body. So when COVID first came out, we were mainly seeing it, like these respiratory symptoms, but then people started having these diarrhea, loss of taste and smell, all these other things with it, rash, all this other stuff, but that's only because ACE is found in other areas of the body, but not as predominant. So you may not have all the GI symptoms, but you can likely have the respiratory symptoms, if you get what I'm saying. Hopefully you guys understand that. So it attaches itself to this enzyme in the lungs, and it just starts causing destruction, starts firing it up. Came here and pew, pew, pew. Sorry. I'm so sorry. Okay. So as I said, it can occur in other areas of the body, GI, integumentary, cardiovascular. Yes, and symptoms vary from person to person. So people may have no symptoms at all. People may have COVID and not know. People may not have may have it and get really, really sick. Okay, so now this patient has COVID. That she's hypoxic, that she's not doing well. What would you guys do? Are you guys going to admit this patient or discharge? Good. People already saying admit. Yeah, she's going to be an admission. She has a lot of risk factors. So, all right. So some things to help you decide whether a COVID patient or any patient is going to be admitted or discharged, especially respiratory, pneumonia type stuff, is if they're septic. All septic patients get admitted. Remember, septic is a bad infection. If they have comorbidities or they're elderly, we said this lady has what? We said she has COPD. So that means she's not going to do well. Her lungs are already not well, so she needs to be admitted. If they have a bilateral pneumonia with it, like the young guy I had, he ended up getting admitted because he had bilateral pneumonia. His symptoms were getting worse. I think he already had symptoms for like over a week or two, and they were getting worse along with the bilateral pneumonia. No bueno. The oxygen, remember, she already came in hypoxic. She could have gotten worse throughout the ED course. If they're a bounce back means that they're already seen. They were determined to have COVID, but they looked fine. They were good enough to go home. But then they came back because they said their symptoms are getting worse. And like I said, worsening symptoms. Vent machine wouldn't typically. That wouldn't be. Usually they don't come in on a vent. Usually could end up being on a vent, if that's what you mean. If they look like they could end up being on a vent or intubated. Yes. If discharge patients are patients with stable vitals, say like I came in, I'm young and healthy, and I'm just cough, but that's just it. And my vitals are completely normal. My labs are normal. My imaging looks great, but I just have COVID. I would go home. I would go home and give instructions. So the patients that go home, stable patients. Their labs are normal. Their ED course was uneventful. ED course means like they're stay throughout the emergency room. No matter how long they've been there, it's uneventful. Nothing crazy happened. Their labs didn't their labs aren't all crazy. Their vitals didn't become abnormal. They look fine. They look healthy. They look good enough to go home. Yeah, when patients have low oxygen, the last thing with COVID, they've been turning to intubation because they try to avoid aerosolizing treatment. So typically the patients will get breathing treatments. They may get on BiPAP, but they avoid that with COVID because it can cause COVID to spread. So that's why if patients decompensated, they would go straight to the vet, because to avoid that aerosolizing treatments that cause the virus to spread even more. Fevers, high fevers are bad. High fevers are not good. So fevers over like 102 or 103, not good. And if a fever is not being managed with Tylenol or Motrin. Of course, these patients would be on isolation, a negative pressure room to prevent spread of the virus. And then treatments different as far as admission and discharge. Admission, we start them on antibiotics to prevent bacterial pneumonia on top of that. And azithromycin has been shown to work. Azithromycin is also called Z-Pak. You guys may know it as that. It's been shown to work or help with management of COVID. They may start on antivirals, not always. We don't ever start them on antivirals in the ER. We usually start them on antibiotics. They may do steroids, vitamin C and zinc, IV fluids, and no inhalers. They'll do like the multi-dose meter dose inhaler, no aerosol, as I said, Tylenol as needed for body aches, fever, and like I said, that's never the case, but intubation or they get on a vent. That's the worst case scenario because it's hard to get these patients off of a vent, but hopefully that's not the case. Negative pressure room is the room that patients go in, isolated COVID patients go in to prevent spread of the virus. Why antibiotics for a virus? Good job. So if you have a virus, you don't give antibiotics. But sometimes if you have like a pneumonia, you want to prevent like it becoming a bacterial infection or just kind of prophylaxis. So that's why we start them on antibiotics. And Z-Pak is like a wonder drug for people. Z-Pak, people give Z-Pak for any and every respiratory thing. All right, and then for discharge patients, it's going to be symptomatic management. Symptomatic means you're managing the symptoms. So if they have a cough, if they have a fever, if they have body aches, you manage the symptoms. You're not necessarily curing the illness, but managing the symptoms. So you're gonna encourage lots of rest and hydration. Let your body do what it got to do. You wouldn't necessarily give discharge patients antibiotics, especially if they don't have a pneumonia. So and with the chest and also to say pneumonia, a chest X-ray is not going to tell you the type of pneumonia. There's people can have viral pneumonia, bacterial pneumonia. It can be due to other pathogens. That's I have a brain fart now, but other pathogens you're not going to know unless you do a sputum sample, which is not going to be done until they get admitted. So that's why we also start on antibiotics. And yes. So zinc, vitamin C help boost your immune system. Tylenol for fever, body aches, antihistamines, cough, cold medicine, sometimes antibiotics if they're discharged. And of course, precautions to return if symptoms get worse. All right. Yeah, oxygen saturations that low definitely get admitted 80 to 85%. Of course, if they're just not doing well at all, they get admitted. I mean, not admitted, intubated. All right. Medical live pearls. Document. Like I said before, make sure you document, cross your I's, dot your T's. Cross your T's, dot your I's. Make sure your document is stellar. Know what's common. Know zebras. Zebras are just uncommon stuff that, know how the patient presents. Know what can kill you. Okay? And know what's common. Those are some pearls for the ER. 22 to 24? No, that's a lot. No, we work if you work 10 hours, you work 14 days a month. A zebra is something that's not common at all that you probably won't ever see in your career. But if you see it, you got to know it. Or you got to at least know that it could be it. Or little symptoms that are known to that. So what is it? What's a zebra? A zebra is necrotizing fasciitis. You'll probably never see that in your career. It's a really, really bad infection. You'll probably never see it in your entire career. I think it starts off as a skin infection. It's a flesh-eating bacteria, but you gotta recognize it when you see it. So that's what a zebra is. You might never ever see it, like I said. A zebra is what is I don't know why they call it zebras. I guess because you never really see a zebra. I don't know. But it basically means that when you see it, you'll never see it, but you kind of it'll stand out to you. Something you gotta know what it is, or you gotta kind of say something's going on here. I don't really know, but okay. Okay, so I hope you guys like that. That's the end of that case study. A unicorn, yeah, they should have called it a unicorn, right? Okay, that's about it. I know. I'm sorry I went over. I'm sorry for the mishap. You guys don't have to watch all 1.5 hour of this when you watch the replay, or if you watch the replay. So I hope you enjoyed it. My IG is Rodeline Joseph _ or @MedSembly. My email is rodelinejoseph@medsembly.com. If you have any questions at all, I'm here for you guys.